Hi everyone, Anna here with the Coding Guild. Today we are going to talk about the latest 2021 EM guideline changes because just recently the AMA made some modifications to the existing guidelines and added clarifications, or as they call, technical corrections to them. The new guidance came out on the 9th of March, but it is retroactive to the beginning of the year. They affect both medical decision-making and time-based leveling. Within medical decision-making, we have a clarification when reporting tests that are considered but not selected after shared decision-making. We have a new definition of what analysis means. The definition of a unique test was clarified. Also was clarified what a discussion is between physicians and other qualified healthcare professionals. Also, the AMA put into writing its opinion on what major and minor surgeries are. As for time-based coding, we have a clarification around which activities will not be allowed to be counted towards the total visit time. And following the AMA document, we will start here with time. The list of allowed activities was not changed, the one that's already in our CPT codebooks, but we were given some no-nos that we could never count towards the level. The performance of other services that are separately reported. This is not new. These are office procedures like wound repairs or joint injections or other separately identifiable EM services such as care management or behavioral counseling. We cannot count time for traveling, nor can we count time for teaching that is general and not limited to discussion that is required for the management of a specific patient. Or in other words, general health tips given to a patient will not count towards the total time of the level, only disease and management specific education. Separately reportable services guideline is further clarified by the AMA. The ordering and actual performance and/or interpretation of diagnostic tests studies during a patient encounter are not included in determining the levels of EM services when the professional interpretation of those tests studies is reported separately by the physician or other qualified healthcare professional reporting the EM service. Notice the significant difference between the old and the new guidance we are given here. In the old guidance, any and all diagnostic test or study that is ordered or performed during the EM visit had to be ruled out from EM leveling, but the new guidance only prohibits us from using diagnostics where the professional interpretation of those tests or studies will be reported separately by the professional. This all means that from now on we have to differentiate between tests and studies that do have a professional interpretive component and those that don't have this component. Let's see first what happens with diagnostics where we have the interpretation component to the code. If the provider gets paid for the mental effort in any way, if they can submit a global CPT code that includes the professional component, or they can submit a CPT code with modifier 26, or they can submit a dedicated interpretation code, in that case, nothing that was leading up to that order or test can be counted towards EM leveling. We cannot give a data point for the order, we cannot give point for the riskiness, we cannot count it as independent interpretation of data, nor can we give a result review data point. Now there are some nuances to this guideline because notice how it can be read in three different ways. The first one is the ordering and actual performance and interpretation of diagnostic test studies during a patient encounter are not included in determining the level of EM services when the professional interpretation is reported separately. This addresses the full diagnostic package performed, such as with the case with in-house X-rays or alike. The second way to read this is the ordering and actual performance during a patient encounter are not included if the professional interpretation is reported separately. This talks about the scenario where the ordering and the actual performance happens during the date of service, but where the interpretation will take place on the following day. For example, with diagnostics where the results are not immediately available. Even if the test result will be read days after the date of service, we are still not allowed to count for the order, the performance, or the review separately as a data point because the provider will submit an interpretive CPT code and get paid for their work. And last, we can read the sentence as follows. The ordering and interpretation of diagnostic tests studies during a patient encounter are not included in determining the levels of EM services when the professional interpretation is reported separately. This read touches upon the situation in which a provider refers a patient to a third party for the performance of a test. Again, regardless of who is administering the test itself, if the ordering provider plans on charging for the interpretation separately, then they cannot give themselves points for ordering the same test. All of these were referring to diagnostics where the professional component exists and is separately reported by the physician. Now let's see the other situation where an interpretive portion does not apply to a code or service. The guidelines continue. Tests that do not require separate interpretation, for example tests that are results only and are analyzed as part of MDM, do not count as an independent interpretation but may be counted as ordered or reviewed for selecting an MDM level. Or to put it differently, if the provider reviews and analyzes diagnostic test results, but there is no way for him or her to report for this work by a separate CPT code because such a code doesn't exist, then they can get paid for their efforts by either gaining 1 point for the order or 1 for the review. Examples here could be some pulmonary diagnostic tests, most lab results, or any service where the goal is to diagnose a problem, but there is no separately reportable interpretation element to the code. It is my understanding that according to these new guidelines, we would be allowed to count a data element for ordering or reviewing in-house labs. And I am basing this opinion on the new guidance whereby the guidelines differentiate between diagnostics with professional component and without professional component. The first half of the guideline explicitly states that if there is a professional component and if the provider is going to charge for that professional component, then it cannot be counted as an MDM element. But the second half of the guidelines seem to state that for as long as there is no professional component to the service or it won't be reported separately, then we can charge for the mental effort by adding it to the EM level and an MDM point. But now we get back to authoritative guidance and the AMA itself. The next change concerns the number and complexity element within MDM. It reads, the final diagnosis for a condition does not in and of itself determine the complexity of risk, as extensive evaluation may be required to reach the conclusion that the signs or symptoms do not represent a highly morbid condition. Therefore, presenting symptoms that are likely to represent a highly morbid condition may drive MDM even when the ultimate diagnosis is not highly morbid. The evaluation and/or treatment should be consistent with the likely nature of the condition. Multiple problems of a lower severity may, in the aggregate, create higher risk due to interaction. This guideline clarifies that even if we end up reporting something minor like chest pain or reflux as the final diagnosis, the complexity of problem might still be high if the provider suspected and feared something highly morbid, like a stroke or a heart attack. There were some initiatives recently from payers to downcode EM services based on the final diagnosis, so I kind of expect that this is a reaction to that. The guidelines continue. The term risk, as used in these definitions, relates to risk from the condition. While condition risk and management risk may often correlate, the risk from the condition is distinct from the risk of the management. This reinforces what we just read, that there is no correlation between the risk of the presenting problem and fear problem being worked up and between the final diagnosis and the treatment decision made. Next, we have a brand new definition for analysis. It reads, analysis is the process of using the data as part of the MDM. The data element itself may not be subject to analysis, for example glucose, but it is instead included in the thought processes for diagnosis, evaluation, or treatment. Tests ordered are presumed to be analyzed when the results are reported. Therefore, when they are ordered during an encounter, they are counted in that encounter. Tests that are ordered outside of an encounter may be counted in the encounter in which they are analyzed. In the case of a recurring order, each new result may be counted in the encounter in which it is analyzed. First important remark. In order to count any test or note review as a data point, they must be included in the thought process and medical decision making. And the only way for us to know it was included is through the documentation. So it is very important to remind providers to please put down all their mental work on paper, otherwise we cannot assign points to them. Second, when a test is ordered, it is expected to be reviewed by the same provider, and this is logical because why would the provider order anything if they have no intention of reviewing the results? And because we have this presumed link between order and review, these tests can only be assigned one data point at the time of their order. Third, and this is new, if an order originates outside of an encounter, then it will be accounted for when its review happens. Last, if there is a recurring order, it will not automatically count as a data point, only and if when it is reviewed, analyzed, and built into the thought process and medical decision making. The definition continues with an example. For example, an encounter that includes an order for monthly prothrombin times would count for one prothrombin time ordered and reviewed. Additional future results, if analyzed in a subsequent encounter, may be counted as a single test in that subsequent encounter. Any service for which the professional component is separately reported by the physician or other qualified healthcare professional reporting the EM services is not counted as a data element ordered, reviewed, analyzed, or independently interpreted for the purposes of determining the level of MDM. Notice again how the word analyzed is added to the definition. Recurring orders must be incorporated into the note in order to count. They must be analyzed. And the second half of the definition reiterates not to count data points for anything where the professional component will be separately reported. So for recurring orders, let's say we have the first order in January. Because the order presumes and assumes the first review, we will get 1 point here for the order, but for the recurring performances of this test and the recurring test results that we receive, we can only assign a point for review if and when the analysis actually happens on that test result. Next, a quick clarification on tests and oximetry. The differentiation between single or multiple tests is defined in accordance with the CPT code set. For the purposes of data reviewed and analyzed, pulse oximetry is not a test. We will see just in a moment what this one means. As for the second half, under the previous definition, oximetry could be counted because they have their own CPT code, but after this clarification, not anymore. And this is understandable because this is a very high volume routine service provided to everybody who enters an office. As for that other part of the test definition where the unique was X'd out, we have a newly added definition defining both unique tests and sources. It starts by saying a unique test is defined by the CPT code set. When multiple results of the same unique test, for example serial blood glucose values, are compared during an EM service, count it as one unique test. To note, the main idea of uniqueness hasn't changed. We still go by CPT codes, but now we have some clarifications on how to go about it. If a test is repeated and said test is described by the same CPT code, it will lose its uniqueness after the first performance. Even though the provider will compare 3 results from 3 different occasions, because they are looking at the same CPT code, it doesn't count as unique anymore. We only can assign one data point for every unique code and not every unique test, if that makes sense. The definition continues. Tests that have overlapping elements are not unique, even if they are identified with distinct CPT codes. For example, a CBC with differential would incorporate the set of hemoglobin, CBC without differential, and platelet count. As we can see from the descriptor of 85025, it indeed incorporates the other 3 tests. These 3, although identified by their own CPT code, will not be accounted for separately as unique if reported with 85025. Finally, the definition ends by clarifying unique sources. A unique source is defined as a physician or qualified healthcare professional in a distinct group or different specialty or subspecialty, or a unique entity. Review of all materials from any unique source counts as one element toward MDM. The first half of the definition is not new, but the second is. Notice how the MDM table had contradictory wording on when and how to account for unique documents reviewed. The column header under amount and complexity of data states that each unique document contributes to the combination of 2 or 3 in category 1. This implies that every documentation reviewed is unique and can be counted as a discharge summary, operative report, and so on and so on. But then the category itself states review of prior external notes from each unique source. The new definition clarifies this by telling us to follow the category instruction and only count one data point for all documentation reviewed per data source. If 5 different progress notes, operative reports, and a discharge summary were reviewed from a recent hospital stay, that will count as one data point from now on because it is one unique source. The next addition addresses the proper use of categories. This was implied before but not spelled out in a guideline. It states combination of data elements, a combination of different data elements, for example, a combination of notes reviewed, test ordered, test reviewed, or independent historian allows these elements to be summed. It does not require each item type or category to be represented. A unique test ordered plus a note reviewed and an independent historian would be a combination of 3 elements. What they are trying to clarify here is that we don't need every single one of those present. We can have any combination within the category. Our next definition regards the content of interprofessional discussions. Discussion requires an interactive exchange. The exchange must be direct and not through intermediaries, for example, clinical staff or trainees. Sending chart notes or written exchanges that are within progress notes does not qualify as interactive exchange. So far, self-explanatory, but here comes the fun part. The discussion does not need to be on the date of the encounter, but it is counted only once and only when it is used in the decision-making of the encounter. It might be asynchronous, does not need to be in person, but it must be initiated and completed within a short time period, for example, within a day or 2. This is a huge difference from the strict requirement to only count services provided on the date of the encounter. So let's see again what we are talking about here. If the provider needs to discuss patient management or test interpretation, they have the option to do it before or after the visit, because notice how the definition doesn't restrict us when this discussion must take place. We have to look out for 2 things though. Was the discussion started and finished within a day or 2? And was it used during the visit where we would like to count it towards the medical decision making? It is hard to imagine how we could use a discussion in progress to use as a data point for same-day service, but an example could be a provider who documents that they initiated a discussion with the pathologist about a recent find, and they will proceed based on the response. Next, we have a clarification next to independent historians. The independent history does not need to be obtained in person, but does need to be obtained directly from the historian providing the independent information. This allows for historians to talk to the provider over the phone, and although it wasn't explicitly forbidden before, now it is specifically allowed, and with coding it's always good to have such clear-cut guidance. The risk element also got a clarification. It reads, one element used in selecting the level of service is the risk of complications and/or morbidity or mortality of patient management at an encounter. This is distinct from the risk of the condition itself. This reinforces what we already saw under the number and complexity of problems addressed, namely that the guidelines clearly distinguish risk associated with the presenting problem versus risk associated with the management of the final diagnosis. For example, a patient might arrive with a seemingly innocent UTI, for which the complexity of problems addressed would stay on the low side. But if after workup we figure that the patient actually suffers from sepsis with acute kidney failure, that could pull the risk way up here in this column. And that is okay because the revised guidelines clarify that risk means different things for the different columns and they can be leveled independent from each other. The risk clarification continues. The risk of patient management criteria applies to the patient management decisions made by the reporting physician or other qualified healthcare professional as part of the reported encounter. So we are to take into consideration those management decisions only that are definitely made during the encounter by the treating provider. For example, if for now the only treatment is physical therapy, and based on the results we will decide on major surgery later in the future, then we can only level according to the management option currently chosen and currently ordered. For this patient, this would be physical therapy with low risk. And while we are at surgeries, the AMA provided definitions for us on how to decide what kind of surgery we should include in the risk level. The new definition reads, "The classification of surgery into minor or major is based on the common meaning of such terms when used by trained clinicians, similar to the use of the term risk. These terms are not defined by a surgical package classification." So, as implied before, the global surgical days are not a factor in deciding whether the surgery is minor or major. Only the operating physician or the proceduralist can decide which one it is. We go on with elective or emergency surgeries. Elective procedures and emergent or urgent procedures describe the timing of a procedure when the timing is related to the patient's condition. An elective procedure is typically planned in advance, scheduled for weeks later, while an emergent procedure is typically performed immediately or with minimal delay to allow for patient stabilization. Both elective and emergent procedures may be minor or major procedures. And this is an interesting idea because when we hear emergent procedure, we mainly think of major life-saving procedures. This definition turns this on its head and clarifies that a minor procedure can be urgent as well. Examples could be perforating foreign body removal from the eye or an urgently performed therapeutic lumbar puncture in order to help the patient with hydrocephalus. And finally, about risk factors. Risk factors are those that are relevant to the patient and procedure. Evidence-based risk calculators may be used but are not required in assessing patient and procedure risk. The main thing we learn here is that risk factors identified must be patient and procedure specific. Stating commonly expected complications such as scarring or infection is not good enough in order to count as an identified risk factor. Documentation must state why this patient and why this procedure is riskier than usual. Next, there is a slight change in the definition of drug therapy requiring monitoring for toxicity. Examples of monitoring that do not qualify include monitoring glucose levels during insulin therapy as the primary reason is the therapeutic effect, unless severe hypoglycemia is a current significant concern. The definition made a switcheroo, and now we can use active glucose monitoring when medically appropriate, while we couldn't have done that before the guideline was changed. And the last change addressed in the new AMA document was made to the instructions on choosing the appropriate MDM level. It reads, "Ordering a test may include those considered but not selected after shared decision making. For example, a patient may request diagnostic imaging that is not necessary for their condition, and discussion of the lack of benefit may be required. Alternatively, a test may normally be performed, but due to the risk for a specific patient, it is not ordered. These considerations must be documented." In other words, tests from now on will behave the same way management options do. If something is considered and documented as being considered, we can count it towards MDM regardless whether it's actually performed or not. And this is all we had for today. I hope it was helpful. You can find the topic-related free quiz on our website as usual. Thank you for being here with me today. I will see you soon in our next video.